Every 66 seconds. That is how often someone in this country is diagnosed with dementia. Not every hour, not every 10 minutes, every 66 seconds. And for most of those people, the diagnosis feels sudden, unexpected, like something that appeared from nowhere. But for a significant proportion of those diagnoses, the cognitive decline was not random. It was not simply the consequence of age. It was being actively accelerated by something they were taking every single day. Something prescribed by their doctor, something filled by their pharmacist, something that came in a bottle with their name on it and instructions that said, take 1 tablet daily. Today I'm going to name 9 specific medications that research has linked to accelerated cognitive decline and increased dementia risk in adults over 60. I'm going to tell you the exact mechanism by which each one damages the brain. I'm going to tell you who is most at risk. And I'm going to give you the precise words to use with your physician to have the most important medication conversation you may have this year. I'm Dr. Richard Whitfield. I've spent over 27 years in internal medicine with a specific focus on the intersection of medication management and cognitive health in adults over 60. And I want to be direct with you at the start of this video. This is not a video designed to frighten you into stopping your medication. Stopping any medication suddenly without medical guidance is never the right answer. What this video is designed to do is give you information that your doctor genuinely may not have communicated clearly, and in some cases may not be fully aware of, because the research on this specific class of medications and dementia risk has become significantly stronger in the last 5 years, and medical practice always lags behind published research. Before we go through all 9 medications, drop your age in the comments and tell me which of the medications I am about to describe you currently take. I read every single comment. Stay with me through all 9. Because medication number 6 is the one I see dismissed most consistently. It is something that millions of seniors take without a prescription. Something sold in the allergy and sleep aisle of every pharmacy in the country. Something that is considered so safe it is given to children. And something that research has linked to a 54% increased risk of Alzheimer's disease in adults who use it regularly for 3 or more years. Let me start with the mechanism, because all 9 medications on today's list share one specific biological pathway through which they damage the brain. Your brain communicates through chemical messengers called neurotransmitters. The most important neurotransmitter for memory, learning, and cognitive function is called acetylcholine. Acetylcholine is involved in the formation of new memories, the retrieval of existing memories, the ability to focus and maintain attention, the speed at which you process new information, and the coordination between different brain regions that allows complex thinking. When acetylcholine is blocked, all of those functions degrade. The term for drugs that block acetylcholine is anticholinergic, and the 9 medications I am about to name all have significant anticholinergic activity. In a younger brain, the effects of occasional anticholinergic exposure are temporary and largely reversible. The brain has enough acetylcholine reserve to compensate. After 60, the brain naturally produces less acetylcholine. The cholinergic neurons, the brain cells that produce and respond to acetylcholine, are among the most vulnerable to age-related decline. Adults with Alzheimer's disease show some of the most dramatic reductions in cholinergic neuron density and acetylcholine levels of any brain condition studied, which means that the brain of an adult over 60 is already operating with reduced acetylcholine reserves. When you add a medication that further blocks the remaining acetylcholine activity, the effect on cognitive function is not compensated for. It accumulates, month after month, year after year, of daily medication that is systematically suppressing the very neurotransmitter system that memory and learning depend on. A landmark study published in JAMA Internal Medicine followed 3,434 adults aged 65 and older for 10 years. The study specifically measured cumulative exposure to anticholinergic medications over the follow-up period. The results were stark. Adults with the highest cumulative anticholinergic exposure had a 54% higher risk of developing dementia than adults with the lowest exposure. 54%. Not a minor statistical association. A more than doubled relative risk from medications that the majority of people taking them considered safe and unremarkable. Now let us go through the 9 medications specifically. Medication 1, diphenhydramine. Brand names: Benadryl, ZzzQuil, Unisom sleep tabs, Tylenol PM, Advil PM, NyQuil. This is one of the most widely used medications in the country. It is the active ingredient in the majority of over-the-counter sleep aids. It is the first-line allergy medication for many adults. And because it does not require a prescription, most people assume it is safe for regular use. Diphenhydramine is a first-generation antihistamine. Its primary mechanism is blocking histamine receptors, but it also powerfully blocks acetylcholine receptors throughout the brain and body. When taken regularly, it is one of the highest anticholinergic burden medications available without a prescription. The JAMA internal medicine study I mentioned found that regular diphenhydramine use for 3 or more years was specifically associated with a 54% elevated dementia risk. The cognitive symptoms of regular diphenhydramine use include memory lapses, word-finding difficulty, difficulty concentrating, and next-day mental fogginess that many people simply attribute to aging. If you take any product containing diphenhydramine regularly, even occasionally for sleep or allergies, bring this to your physician. Safer alternatives exist for both indications. For sleep, low-dose melatonin, magnesium glycinate, or CBT1 behavioral therapy are all evidence-based alternatives without anticholinergic risk. For allergies, second-generation antihistamines including cetirizine, Zyrtec, and loratadine, Claritin, are as effective for most allergies and have minimal anticholinergic activity. Medication 2. Oxybutynin. Brand names: Ditropan, Oxytrol. Oxybutynin is prescribed for overactive bladder. It is one of the most commonly prescribed medications for seniors who experience urgency, frequency, or bladder leakage. And it is one of the highest rated anticholinergic medications on the Anticholinergic Cognitive Burden Scale, a standardized pharmacological tool used to measure medication-related cognitive risk. The same mechanism that relaxes the bladder muscle, anticholinergic blockade, also crosses the blood-brain barrier and blocks acetylcholine receptors in the brain. Research published in the journal Drugs and Aging found that older adults on oxybutynin showed measurably worse performance on cognitive tests compared to age-matched adults on non-anticholinergic bladder medications, with cognitive differences appearing as quickly as 2 months after starting the medication. The alternatives are important here. Newer bladder medications, including mirabegron, work through a completely different mechanism that does not involve acetylcholine blockade, and have shown comparable bladder efficacy with substantially lower cognitive risk. If you take oxybutynin, ask your physician specifically, is mirabegron or another non-anticholinergic alternative appropriate for my bladder condition? Medication 3. Amitriptyline and other tricyclic antidepressants. Brand names: Elavil, Endep, Pamelor, Norpramin. Tricyclic antidepressants are an older class of antidepressants that also have significant pain-relieving properties. They are frequently prescribed for chronic pain, particularly nerve pain, fibromyalgia, migraine prevention, sleep disorders, depression in adults for whom newer antidepressants have been ineffective. Amitriptyline in particular carries one of the highest anticholinergic burdens of any commonly prescribed medication. It is listed on the American Geriatric Society Beers criteria, which is the gold standard reference for medications that are potentially inappropriate for adults over 65. It has been on that list for decades, and yet it continues to be prescribed to seniors regularly, often by specialists who are not primarily focused on geriatric cognitive risk. If you take any tricyclic antidepressant, a direct conversation about anticholinergic risk and alternative medications is one of the most important medication conversations you can have with your physician. Medication 4. Tolterodine. Brand name: Detrol. Another bladder medication similar to oxybutynin in its mechanism and in its cognitive risk profile. Also listed on the Beers criteria. Also associated with measurable cognitive decline in adults over 65 in multiple studies. The same mirabegron alternative I mentioned for oxybutynin applies here. Medication 5. Hydroxyzine. Brand names: Atarax, Vistaril. Hydroxyzine is prescribed for anxiety, for itching, and frequently as a sleep aid. It is sometimes presented to patients as a non-addictive alternative to benzodiazepines for anxiety or sleep. And in terms of addiction potential, that framing is accurate. But hydroxyzine carries significant anticholinergic activity that the comparison with benzodiazepines obscures. Trading the addiction risk of a benzodiazepine for the cognitive risk of an anticholinergic is not a clearly better trade for an adult over 60. If you take hydroxyzine for anxiety, Ask your physician about non-anticholinergic anxiety management options, including buspirone, SSRIs, or evidence-based behavioral approaches. If you take it for sleep, the alternatives I mentioned for diphenhydramine apply equally. Medication 6. And this is the one most people dismiss. Diphenhydramine in combination cold, flu, and pain products. This is not a different drug from medication 1. It is the same drug. But it appears here separately because the vast majority of people taking it in this context have no idea they are taking diphenhydramine at all. Tylenol PM, Advil PM, NyQuil, Theraflu, many Benadryl allergy products, numerous generic store brand sleep aids. All of these contain diphenhydramine. A person who carefully reads their Benadryl label and knows they are taking diphenhydramine may still be unknowingly taking additional doses through their nighttime cold product, their pain reliever PM formulation, and their allergy relief tablet. The combined daily diphenhydramine exposure from multiple products taken simultaneously can reach levels significantly higher than any single product's recommended dose. And the cumulative anticholinergic burden from that combined exposure compounds the cognitive risk of each individual product. Here is what I want you to do today. Go to your medicine cabinet. Take out every over-the-counter product you take regularly. Turn each one over. Look at the active ingredients. Find the word diphenhydramine and count how many products it appears in. The answer may surprise you. Medication 7. Paroxetine. Brand name, Paxil. Paroxetine is an antidepressant in the SSRI class, which means it is a newer antidepressant than the tricyclics. But paroxetine is an unusual SSRI in that it has significantly higher anticholinergic activity than other SSRIs, including sertraline, Zoloft, escitalopram, Lexapro, and fluoxetine, Prozac. For adults over 60 who need antidepressant medication, paroxetine's cognitive risk profile makes it a less favorable choice than other SSRIs that achieve similar antidepressant efficacy without the same anticholinergic burden. If you take paroxetine, this is worth raising with the prescribing physician, not to discontinue antidepressant treatment, but to discuss whether a lower anticholinergic SSRI alternative would be equally effective for your specific presentation. Medication 8. Doxylamine. Brand names. Unisom sleep tabs, different formulation. Certain NyQuil products. Doxylamine is the other primary over-the-counter sleep aid ingredient alongside diphenhydramine. It is a first-generation antihistamine with the same anticholinergic mechanism and the same cognitive risk profile as diphenhydramine. The same cautions apply. Medication 9. Promethazine. Brand names. Phenergan, various combination products. Promethazine is a first-generation antihistamine prescribed for nausea, motion sickness, and sometimes as a pre-surgical sedative. It carries very high anticholinergic activity. It is specifically listed on the American Geriatric Society Beers criteria as a medication to avoid in adults over 65. Safer alternatives for nausea in adults over 60 include ondansetron and metoclopramide, which achieve similar nausea control through different mechanisms without anticholinergic cognitive risk. Mid-video pause. If any of these 9 medications appear in your own medicine cabinet, tap the like button right now and drop in the comments which ones you recognize from your own daily routine. I guarantee the responses will show that this is far more widespread than most people realize. This information needs to reach every senior who is taking these medications without knowing what the research has been consistently showing for the last decade. The anticholinergic burden concept. I want to explain something that is important for understanding your total risk, not just your risk from any individual medication. Pharmacologists who study this area use a concept called anticholinergic burden. It is not about any single medication in isolation. It is about the cumulative blockade of acetylcholine receptors from all medications you take simultaneously. A person taking one mildly anticholinergic medication has a different risk profile than a person taking 3 medications, each with moderate anticholinergic activity. The effects do not simply add, they multiply, because the cholinergic system is being attacked from multiple directions simultaneously. A study published in JAMA Internal Medicine specifically examined anticholinergic burden in adults over 65 and found that the dementia risk associated with high cumulative anticholinergic burden was not explainable by any single medication alone, but by the total anticholinergic load across all medications taken concurrently. This means that even if none of your individual medications reaches the threshold of concern on its own, the combination of several moderately anticholinergic medications may produce a total burden that meaningfully elevates your cognitive risk. There's a validated tool called the Anticholinergic Cognitive Burden Scale that rates each medication on a scale from 0 to 3 based on its anticholinergic activity. Your total burden is the sum of the scores of all your medications. Ask your physician or pharmacist specifically, what is my total anticholinergic burden score based on everything I take? That question is specific, it is clinical, and it will immediately communicate that you understand what you are asking about. What to bring to your next appointment. I want to close this video with precise, actionable guidance, because I know from experience that people leave videos like this feeling alarmed and not knowing what to do. Here is what to do. Step 1. Make a complete list of every medication you take, both prescription and over-the-counter. Include any products you take only occasionally for sleep, allergy, or pain. Step 2. Check each one for anticholinergic activity. The Anticholinergic Cognitive Burden Scale is available online and can be searched directly. Look up each of your medications. Step 3. Bring the list and your research to your next appointment and say these specific words. I have been reading about the relationship between anticholinergic medication burden and dementia risk in adults over 65. I would like to review my current medications with you to understand my total anticholinergic burden and discuss whether any alternatives with lower cognitive risk exist for the conditions I am managing. That statement is not telling your physician what to do. It is starting a specific clinical conversation that your physician will respect and engage with seriously. Some of your medications will have direct alternatives with lower anticholinergic risk. Some will not. There will be cases where the benefit of the medication genuinely outweighs the cognitive risk, particularly for serious conditions with no alternatives. But the conversation itself is the protection. The protection is not stopping medication blindly. It is understanding what every medication you take is doing to every organ in your body, including your brain. Your memory is not declining because of age alone. For millions of adults over 60 taking these 9 medications daily, the decline is being chemically assisted, and a conversation with your physician can change that. And if you want to understand the single dietary change that directly supports the acetylcholine system your medications may be depleting, watch the next video on this channel right now. I'm Dr. Richard Whitfield. Stay informed, and I will see you in the next one.